Thank you. Good morning and welcome to Paris. This morning I'm going to cover a little bit about rapid musculoskeletal imaging. This are my financial disclosures. I receive research support from GE Healthcare. As an outline, I'm going to talk a little bit about the motivation for rapid musculoskeletal MRI, some anatomic 3D imaging with more physiologic contrast or information, and then what the newer technologies such as compressed sensing and machine learning can do for us in this area. So musculoskeletal protocols are typically long. They're usually half an hour time slots on the scanner, sometimes longer. This is an example of our clinical protocol at Stanford. It produces beautiful images with multiple planes of two-dimensional fast spin echo, but it takes quite a long time. And the surgeons are very happy with the image quality, but the folks running the scanners are not so happy with the amount of time this takes. So one of the great potentials that has been out there for quite some time now to improve the speed and efficiency of musculoskeletal imaging has been going to three-dimensional imaging. If you look at it from a basic perspective, 2D multi-slice imaging has shorter scan times than 3D imaging typically, and it's efficient when the TR is long enough that you can interleave all the slice acquisitions into one repetition time. But 3D imaging has significant advantages compared with 2D, is that every acquisition gets information from the entire volume, so it helps with the overall signal to noise. You don't have potential slice gaps, you have continuous coverage. And if you can achieve isotropic resolution, you can reformat the images into any plane you like volumetric CT does these days. So 10 years ago or more, I started looking at this problem, looking at three-dimensional fast spin echo, which is a sequence that was developed by John Mugler and was initially looked at in MSK and continues to be looked at. And basically, you see improved contrast to noise and SNR efficiency from 3D, higher in-plane spatial resolution and thinner slices than 2D. But the overall image quality, as you can see here at the bottom of the screen, is not as pleasing to the eye as the two-dimensional slice. And we believe this is due to blurring from the long echo trains to get this 3D acquisition down to a reasonable scan time. Here's an example of, on the left, FatSat 3D fast spin echo at two different resolutions here, showing that isotropic resolution in this case with a thinner slice of 0.7 millimeters shows this cartilage fissure to greater advantage than the thicker slice acquisition. So with our 2D fast spin echo, I think we probably just don't know what we're missing in terms of the through slice averaging that when we look at our images. So what can we do for 3D imaging? Well, for a long time, we've had gradient echo imaging available. This produces beautiful images with high resolution where you can get different types of contrast, T2 or T2 star contrast, where you can make fluid bright. But it has the disadvantage of not being as sensitive to bone marrow edema or bone marrow lesions as conventional spin echo imaging. In the osteoarthritis initiative and in other research studies, double echo steady state imaging has proved to be very valuable where you acquire two different echoes of a gradient echo sequence and you can add these up to a sum image, you can take a difference image, or you can post-process this in a number of different ways. So the first echo is T1 over T2 weighted, and the second echo is T2 and diffusion weighted. So in this case, we examined DES to look at both morphometry and T2 quantification. So these are the first echo images in the first column, the second echo images with more of a T2 weighting in the middle column, and then on the right side is the quantified T2 map, which can be calculated from the DES data. And this is not an isotropic resolution acquisition, but good enough that you can get reasonable reformats in about 5 minutes. So we compared this 5-minute DES protocol with the different contrast to our conventional FSE protocol, and we're able to see the usual things we're looking for on clinical scans, such as an ACL tear here on the DES S- image, as well as on the T2 map, meniscal tears on the conventional sequences, and also on the DES images and on the coronal reformat images as well. So much of the same information is there with a single 3D acquisition that we see with our conventional protocol. Here are some cartilage fibrillation with the two different DES contrasts. There are other ways to do the 3D acquisition. This is from the Wisconsin group, using a radial steady-state free precession technique here, which has a great scan efficiency compared with Cartesian methods, and also allows you to get very short echo times. Here's an example showing a meniscal tear and an ACL tear using this method. This has an isotropic resolution of about 0.3 or 0.4 millimeters. Here again, compared with the FATSAT 2D fast spin echo, we get cleaner depiction of the trochlear cartilage, and we do see some of the bone marrow lesion, although it's not as bright as it is on the 2D fast spin echo approach. So with 3D fast spin echo, as I mentioned, this has tremendous potential to do an isotropic acquisition such as shown here. This is an old slide. This was acquired in 8 minutes with the coronal acquisition and sagittal and axial reformats. So this acquires 200 images in the coronal plane with a fast spin echo or spin echo contrast, and has an isotropic resolution. So like 3D CT, it's fairly easy to reformat this into different planes, such as the sagittal plane here. So in principle, if you don't mind having a single type of intermediate or proton density weighted contrast, you could replace all of your knee sequences with a single isotropic acquisition for a clinical scan. And here's an example of a meniscal fragment here in the gutter seen on an oblique axial image here from our 3D acquisition, where we can see the full extent of this fragment very nicely. You can do a lot of things with these 3D sequences, and they're improving greatly in terms of their quality. This is from Mike Recht at NYU, showing a flipped posterior horn of the lateral meniscus here on the 2D turbo spin echo, and then here on the space scan, which is the Siemens lingo for three-dimensional turbo or fast spin echo. Here again, compared with 2D turbo spin echo and 3D fast spin echo or turbo spin echo, you can note that the 3D image still doesn't quite achieve the same image quality pleasing to the eye in terms of the 2D image, but it's getting a lot closer. Here again, showing a ACL tear on both of these sequences. And here a meniscal tear with a perimeniscal cyst. So the studies that have been done looking at 3D fast spin echo show that it's equivalent in terms of its depiction of pathology, but it's not as pleasing to the eye and hasn't caught on clinically yet. You can go even higher resolution morphologically at 7 Tesla. This is from Neil Bangarter, a 0.3 millimeter isotropic 3D acquisition. This is done with balanced SSFP. It's an 8-minute scan time, but beautiful isotropic resolution with reformats. And you can compare this with both DES imaging and 3D fast spin echo imaging in terms of the overall quality of the acquisition. UTE imaging is another area that could benefit greatly from 3D and has in recent years. A 3D conical acquisition is more recent in UTE imaging than the prior half pulses that were used in the initial scanning. Here you even see some signal posterior to the joint out in the air here. This is plastic in the coil that's generating some MR signal. And the subtraction image here shows that quite well. Some of these sequences have even gone on to be called zero TE. This is a particular technique that interleaves the RF pulses with the acquisition and achieves near zero echo time based on some work that Mike Garwood did at CMRR in Minnesota. Here's an isotropic 3D ZTE image of the cervical spine compared with a CT scan. So this is really getting us close to depicting CT-like images from MR scans. Here's some 3D reconstructions from Hospital Special Surgery Group. This is Hollis Potter and Matt Koff's group showing reconstructions of shoulder anatomy with some suture anchors here seen in the glenoid, both on ZTE and CT images. Very similar resolutions between these two acquisitions. Here in the hip joint, looking for anatomy related to femoroacetabular impingement, we can avoid doing a radiation dose to these young patients and instead acquire the morphologic information with a ZTE MR approach at the same time we're evaluating the soft tissues. 3D imaging has also been very helpful for physiologic research imaging, T2 maps in this case with three-dimensional fast spin echo and T1 row maps with three-dimensional fast spin echo give you the potential to get the morphology and the physiology in a single measurement. This is also helpful in looking at short T2 structures with UTE techniques such as a Cohn's T2 star approach to measure the T2 star relaxation time, in this case in the patella tendon. Here, looking at the change in the T2 star with tendinopathy on the bottom versus a healthy volunteer on the top, looking at both the fast and the slow relaxation components of the T2 star to try to better characterize the actual internal degeneration in the tendon. "3D UTE MR has also been used in the setting of injury to look at the articular cartilage, particularly the calcified layer of the articular cartilage. And Connie Chu and her group at Stanford have shown that the deep layer of the articular cartilage, T2 star relaxation time as measured by this technique, correlates with the recovery of patients from an ACL injury and potentially with the development of post-traumatic osteoarthritis. Sodium imaging is something that benefits greatly from 3D imaging and is still an enormous problem in terms of a very long scan time. So we're going to be looking at the last techniques I'm going to talk about to speed this up. Sodium is a way that we can get at the proteoglycan content of the articular cartilage. This is a patient 10 years after an ACL injury. This was a study done at 3T. Trochlear cartilage looks normal on the anatomic scan, but we get decreased sodium concentration on the sodium scan. So what about compressed sensing and machine learning? Compressed sensing is basically a way that we can go beyond normal parallel imaging to take advantage of the sparsity of the MR data in K-space to improve the overall quality of the parallel imaging reconstructions. So this is again from the NYU group showing axial T2 imaging here with IPAT, which is conventional parallel imaging with a scan time of about 3 minutes, compared with a compressed sensing image with a scan time of about half that. So it's a way we can extend the parallel imaging and go even faster. Here's another example, again, about half the overall scan time with very little reduction in overall image quality due to the compressed sensing. Again, here in a sagittal example, you can apply this in cases where the scan time is already long, such as metal reduction imaging or multispectral imaging. In this case, a standard stir scan here and an accelerated stir scan here, which is less than half the scan time using compressed sensing. And here, intermediate weighted scans with CMAC technique, standard, and with the accelerated method here, looking at a total hip replacement. We can also apply this to sodium imaging to get smaller voxel sizes in a reduction in scan time, which is very important if this technique is ever going to make it into clinical practice. A 21-minute scan is not going to cut it in clinical practice, but a 10-minute or a 7-minute scan for this kind of information might. And again, here, accelerating 3D T1 row imaging with this resolution with a acceleration factor of 3, taking this scan time down from roughly 10 minutes to about 3.5 minutes. Machine learning is taking over the ISMRM in some form this last year, and we'll see a lot of it this year as well. We held our first machine learning workshop down in Asilomar earlier this year. It has tremendous applications for many areas in MR imaging. It has the potential to take a very noisy and artifact-prone image like this IPAT factor 4 parallel imaging study here and improve the overall depiction of the anatomy, and in this case the pathology, by using a machine learning reconstruction that's trained off of training data. And again, this is from the NYU group. Again, here showing a bucket handle tear on the left with a conventional parallel imaging acquisition on the right with a machine learning reconstruction. And again, here a meniscal tear, conventional parallel imaging, machine learning reconstruction that allows us to do this acquisition much faster with very little loss in image quality. Now, two areas that have been looked at with machine learning are so-called super resolution and segmentation. So in this study from Akshay Chandari and Brian Hargreaves' group at Stanford, the idea here was to acquire thin slice MRI at 0.7 millimeters, simulate the acquisition of 3 times thicker slices, and then use a convolutional neural network to recover the 0.7 millimeter acquisition. So we have a high resolution ground truth training set. We use a convolutional neural network that Akshay calls DeepResolve, which takes the low resolution simulated images, interpolates them, compares them to the high resolution ground truth, and then reconstructs them at a higher resolution, so-called super resolution. This is what the DeepResolve looks like. The most important point here is the low resolution images go in and the high resolution images come out after this learning reconstruction. So on the left is a ground truth image. This is the 0.7 millimeter acquisition. This is the DeepResolve reconstruction of that image. It's not quite the same as the ground truth, but it's a lot closer than the traditional interpolated image, which we might do to improve the overall slice resolution, the tricubic interpolation. Again, here on the left, ground truth. In the middle, DeepResolve with this meniscal tear and perimeniscal cyst. Very superior to the typical approach to improving the slice resolution through interpolation. So the second goal is to automate segmentation with machine learning. So can we use this type of technique to automatically segment the cartilage and then evaluate the segmentation accuracy compared with ground truth and cubic interpolation methods? So this uses a slightly different machine learning architecture called a UNet, a 3D UNet, where the images are downsampled into bits and then upsampled into a super resolution output. The network is trained with dynamic learning and dropout with continuous dice coefficient, which is a way to compare similarity in images, a loss function, and a full 3D segmentation with no manual post-processing. So the ground truth versus the super resolution shows that they're very similar, close to 97% in the overall dice score. The coefficient of variation of the automated segmentation is at the low end of the range of inner reader coefficients of variation of segmentation of the articular cartilage, indicating that the super resolution works in this case for the automated segmentation. Here's an example of similar work from UCSF. This is from Valentina Padoya and Sharmila Majumdar, looking at the hip here, segmenting the articular cartilage in the hip joint with a two-dimensional UNet architecture, and again looking at the ground truth here versus the automatic segmentation, doing quite well. Here's another example where deep learning extracts the data-driven T2 features from the MR images with an improved classification of OA. So what they've done is taken a lot of subjects from the OAI, classified them based on their X-ray osteoarthritis grade, and then looked at the ability to classify OA from the T2 maps, and they're able to improve the area under the curve here to 0.78% in this case. So in conclusion, I think that 3D MR can improve the spatial resolution, contrast, and speed of musculoskeletal MR. We're seeing continuous improvements in terms of the acquisition and reconstruction of the 3D data, and in particular, the recent advances in compressed sensing and machine learning, I think, are going to make high-quality isotropic acquisitions of musculoskeletal images a routine thing going forward. This is chiefly through enhancing the image quality by reducing blurring and other artifacts that we see on prior iterations of three-dimensional fast-spin echo. There are other approaches as well, like T2 shuffling and simultaneous multi-slice imaging, which I didn't have time to cover here. But at the end of the day, we're going to be getting isotropic resolution images that we can reformat in a quick amount of time. And if we do super resolution and segmentation versus with the AI and machine learning, we have the potential to rapidly acquire a lot of data, information about the knee joint or about another joint in the body, and then automatically segment that and use that as a front end into biomechanical models or other approaches to analysis of joint function. Thank you.